Beautiful. Well, welcome all that are here. I'm just going to give some brief introductions to the wonderful panelists that we have here. So starting off, we have Dr. Wendy Oliver Pyatt. She is a world-leading expert on treating eating disorders with more than 25 years of clinical experience. She has developed 5 distinctive treatment programs, all grounded on a strong biosocial foundation and incorporating intensive psychotherapy with behavioral foundations with high medical standards. Wendy has developed a unique treatment approach that devolves into the underlying issues that place a person at a risk for mental health conditions and eating disorders and lead us to healing, health, and inner peace. Welcome, Wendy. We're so happy to have you as always. I also want to introduce Dr. Tom Weigel. He strives to make healthcare a more inclusive and accessible system for all Vermonters. He supports both collaboration and integration of medical and mental health care. For more than a decade, he has served as the director in the hospital level administration, clinical programs, and government agencies. Dr. Weigel's focus has been on the quality improvement and outcome measurement. Before joining Blue Cross, Dr. Weigel was the medical director at the Vermont Department of Mental Health, where he worked on payment reform. Welcome, Dr. Tom Weigel. And last but not least, we have Dr. David Alperovitz. He has worked over 25 years of experience working at McLean Hospital, primarily with the individuals with OCD, eating disorders, trauma histories, and dissociative symptoms. He has maintained a private practice treating adolescents and adults for close to 20 years. Dr. Alperovitz joined the staff at the OCD Institute as a behavioral therapist in 2018. He is currently the program director of the Klarman Eating Disorder Center. And today our topic for the panel will be taking behavioral healthcare to new heights, a personalized approach. So welcome everybody. We're so excited to have this panel today. So to kick things off, I have a question for any of the panelists. How can a personalized approach in behavioral healthcare improve patient outcomes compared to traditional one-size-fits-all methods?
You want to start on that one, David, and then I can maybe kick off a little follow-up?
Yeah, I mean, it's a great question, and the answer seems obvious, right? You want the more personalized the care, the better the outcome, because you're really targeting what the person is struggling with. But it's not a simple answer because, in some ways, particularly when you're working within a program, you have to pay heed to the program at large, and there are some need for consistency and protocols and rules, and it's within that I think you find the nuances of individualized and personalized care. So it's not a simple answer, although it seems like on its face that, yeah, of course, the more personalized, the better. But you sometimes find yourself having to navigate and work within systems. So generally speaking, the answer is yes, of course, but it's more nuanced than that when you delve into it.
Yeah, I couldn't agree more. I think one of the things that is difficult for patients and families to sometimes understand is that, some of the things that feel abrasive or don't feel fun to have to deal with are actually a part of the treatment as well. And so that is also a piece of it that's especially difficult with eating disorders, because eating disorders are a condition of generally like more poor on the spectrum, more poor insight, and a little bit more on the ego syntonic versus ego dystonic side. So we have to strike that balance between that collaboration and that connection, while at the same time helping people find that doable edge, because it is also tied to exposure therapy and doing things, that are difficult for the patients to do. But I think if on the personalized piece of it, if people can understand like why we are doing certain things, even when they're difficult, like if you show them an exposure curve, I usually show them an exposure curve and say, people live and die going up and down on this exposure curve, not knowing there's another side of it. So I think if you can personalize it so that people can make sense, like not treat our patients or families like they're incapable of understanding our reasoning. If we can explain what we're doing and why it's going to matter to that human being to eat a slice of pizza, or to be able, to go somewhere, alone, or maybe go grocery shopping, and be able to do that independently. So if we can explain these things, then people have like more hope, and more motivation. And then the only thing I always tell my patients this too, is like, everybody doesn't get the same treatment. Sometimes they say, oh, but Sally got this and John got that. And it's like, well, yeah, because John is John and Sally is Sally. So sometimes the patients kind of think everybody should have the equal treatment. But I mean, it's the same in families. Like you might have one kid that has ADHD and one kid that has OCD, and like they're going to need different things. So that's a part of personalized care too, is tailoring it, like you said, to the actual presentation.
I'll just add, Wendy, because I think that was such a good point about the exposure work, especially when we're working with someone to personalize and individualize a plan, but it may be counterintuitive and it may go against their instincts and against their primal sort of fear. There has to be a rationale for why they would lean in and do something that their instincts are telling them not to do. So really explaining what that rational reason would be in a very personalized way. What is the reason for doing this? Is it to reconnect with family? What has gotten in the way? Are you missing work? Are you unable to pursue something that you're interested in? And that's something that they can really sort of, in a very personal way, grab onto. And it underscores the whole rationale for doing something that may be counterintuitive, and all their instincts are telling them, I don't want any part of this.
Yeah, for sure. That's such a good point. I mean, we could go on and on about exposure therapy, right? I always try to tell, even when I'm training staff, like, when we're trying to get our clients to eat, that mac and cheese, it probably feels how I might feel if a bug was crawling at my arm right now. I would be like, I'd have high alert, I'd be fear-based, I'd be reactive. And just understanding that as far as exposure therapy is important, I think. So again, we probably could just go to town on this question. So we better keep going, right?
Thank you both. That was such great insight. I really appreciate it. Another question that we have for the panel: what role do healthcare providers play in tailoring mental health and behavioral interventions to meet individual patient needs?
Okay, I'll do a quick kickoff. I think that a word that I love and I use a lot in my programs is attunement. So attunement is really the foundation for a collaborative healing relationship between a provider and a patient or client. And oftentimes that also, not only is the relationship important, but psychoeducation is very, very, very important. And in addition to psychoeducation, family psychoeducation is important. So we really have to see, especially with eating disorders, but in general, when we have like a behavioral health matter, we really need to use a biopsychosocial model. And that's, Hilda Brooke was a psychiatrist that brought that back to life. She didn't create the biopsychosocial model, but she brought it to life because it has so much applicability to eating disorders. And so using that biopsychosocial model, there is a very important piece in tailoring mental health care to also working with the family, because the family, sometimes I call it three-pronged: family therapy, family education, and family coaching. And there's a variation of what is going to work best for any family. Some therapy isn't going to get very far, but if you can sit down and do some education and some coaching, you can really, really help the situation. So I think using a biopsychosocial foundation and being attuned and really seeing your patient as, that's what we call things partner. We have partnership meetings because it's really about partnering with people and getting away from that hierarchical model of like doctors know best type of thing.
I think I was just going to add that in addition, I think it's kind of level of care and also types of treatments. For example, in an IOP, PHP, or residential program, you're going to have lots of different therapies: individual, family, group. I remember when I was training at Mass General, one of one of the psychoanalysts was talking about group therapy, and they said, for some people it's just a lot easier because in an individual meeting there's a lot more intense feelings, but that transference can kind of be diffused in a group setting. There's some patients, some people, some struggles that are just better handled in a group. One might be support. One might be talking about difficulties that someone struggles with. I always feel like this when this happens, and 4 other people say, yeah, I feel that way too. You can get a lot of support and validity from that. So I think some of tailoring treatment is knowing, what types of treatment somebody might most benefit from.
Such an important point. David, were you going to add to that?
Yeah, I mean, I think following on what both of you are saying, and I always have this dilemma when I'm meeting someone for the first time. How much information do I want ahead of time? On the one hand, there's a practical usefulness in terms of getting some background information, but it's all kind of on paper. It's, the other wish on the other side is like, I want to know nothing. I just want to meet them and hear it from them and sort of attune to where they are in that moment and what's brought them to me. But I think it's probably a combination of both that helps sort of outline where you meet them and how you meet them. There's certainly some practical utility in having some background information, but you also really don't know where someone is and what they actually will need or what they're willing to do until you sit down and meet with them. So, and that's not a process necessarily that unfolds in one session. It may be sort of an ongoing challenge as well. And it may be something that you come back to as you begin working.
Yeah, I wanted to just add, since Tom, you brought up the whole thing about level of care. When I'm training like psychiatrists or therapists or whatever, I like to kind of reiterate the point that the decision about level of care that the person needs is a crucial decision. Because if somebody needs an IOP or a PHP or residential level of care and you're working with them in an outpatient setting, it's really like just not okay. So making sure that we're aligning with the level of care needs is so important. It's one of the reasons I'm so happy about within that we can actually bring that milieu in a sense to the patient wherever they're at. And Tom, you mentioned the group. I mean, the power of groups is amazing. Obviously, one of the problems in behavioral health is when these groups get very, very large. It's more like roll call, but a true milieu where the clients or patients are supporting one another and seeing the things that they have in common, inspiring one another, and really creating what I call a pro-recovery social environment. It does require smaller groups and high frequency of individual therapy, I think, to keep the milieu recovery oriented. But the power of groups is amazing and the level of care is vital.
Wonderful. Thank you, panel. To move on to the next question, telehealth has become more prevalent in behavioral health care. How can personalized care be effectively delivered through telehealth platforms, and what are the implications for reimbursement and coverage by the payers?
It's interesting. When I on the first question around personalized care, I was also jotting down some notes, and there's almost like levels of personalization. And group therapy is a little less personal than one-on-one, but there's also some of the companies now are coming out with digital solutions. So digital solutions around stress management, insomnia, mild symptoms of anxiety or depression. I remember when I was learning, cognitive behavioral therapy for panic disorder, it was like a 12 or 14 sessions. Here's the workbook. This is what you discuss on each day, and this is the homework. My thought was, well, you could record this, right? And so, some of the solutions can actually be really impersonal, less personal or impersonal for some of those solutions. From the telehealth perspective, it's been amazing. In Vermont and a lot of areas of the country, Vermont's very rural. We have Burlington, which is pretty small. Our entire state is about 650,000 people, which I think is smaller than Boston. So we have trouble with access to care. A lot of people live on dirt roads and have trouble getting into appointments. Even if we had, we now have one brick and mortar eating disorder facility, but even if we had 5 or 6, nobody could get to each one because of the distance. And so telehealth is really amazing that people can attend appointments from their home, from their office. You're less likely to get canceled appointments. We used to, when I was in practice, I used to get canceled appointments if the child got sick, if the parent got sick, if the car broke down, somebody got stuck in traffic. All the no-show rates are really low, and people can block off an hour for treatment rather than 3 hours trying to get somewhere and back. And likewise with something like PHP or IOP, you can tailor an IOP program. So, for example, if you have a brick and mortar IOP program, people might show up from 4 till 7, 3 days a week, and whatever programming you have on at that time, that's what somebody's going to get. But if somebody, let's say, has an eating disorder, also some substance use issues, and there's a group at 8 a.m. that day regarding those issues, you could actually plug somebody in at an 8 a.m. meeting before work, a noontime meeting at lunch, and an hour meeting at the end of the day that's really tailored to their specific symptoms. For eating disorders, it might be around, bulimia versus anorexia symptoms, or substance use, or as David mentioned, OCD-related symptoms. So you can sometimes tailor treatments a lot better with that virtual care.
Yeah, for sure. I'll just maybe dovetail on that. The thing that really got me, there's so many things that got me excited about doing the remote care, was the idea that we could wrap our services around a person's life in the in the areas that they're functioning well. They could continue to function well in those areas while we can, for a PHP patient, we can do a morning meal in a group, then we could do meal support at lunch, then we could do maybe have an individual session in 2 groups in the evening, and really scatter it throughout the day in a way that really plugs in, with the patient's life. We have over 55 different groups available in 4 time zones. So we do that individualization. We actually have an ARFID support group, which is, I think, possibly the largest ARFID group that probably exists. We have a group that is for individuals who are professionals that have problems with eating disorders, LGBTQ, we have, male loved ones, etc. So with this larger platform, you're able to create these cohorts and these groups that can be really, individualized. We have a breakfast club for moms. And these moms just get together and eat breakfast together. And it's just really, really nice, to see that. And then, as you mentioned, it's just so much easier for people to get, in and out of treatment when they don't have to drive or go anywhere. I want to say too, I just want to shout out to our patients, because I think that there's been in this field, sort of a judgment, you hear that language of oh, she just, or he just doesn't want to get better. And I'm not going to work harder than the patient. And, when you get into these real-time situations that I've encountered at Within, we've encountered so many people that have come to our program that just literally can't go. It's not because they don't want to get better or they want the provider to work harder. It's, one of our first patients lived in Dayton, Nevada, had a broken foot. Another of our very first patient that ever signed up for Within Health was in a rural area of Oregon, and she was a massage therapist. And if she didn't do that, if she didn't do her massage work, she couldn't pay her rent. So these judgments that we have about people who haven't maybe gone to care are really, I think, misguided. And then also we see people with a length of stay of about 90 days at Within, which tells me they're getting something meaningful out of this. And it really warms my heart, because I'm thinking to myself, well, this person's at home, they could go walk the dog, take a nap, watch Netflix or whatever. And even at the PHP level, they're getting on with that group. They're connecting with their therapist and their team. And it just really shows that they really people want help. It's just been really hard to get it. And we just make it so much easier through telehealth. And it's not just, Within, but in general, we make it just so much easier. Not to mean that we don't need our brick and mortar state, because we do. And we refer to higher levels of care when we need to in a brick and mortar setting, for sure.
I'll just add, the other thing that it opens up different possibilities. In fact, I've had someone in our residential program go home and do remote virtual sessions with them because the importance of them being in their home environment, we couldn't replicate that in a way that was very useful within the residence. And that was where they primarily struggled. That could be for meal coaching, for OCD, if it's, their contamination fears around their home. What better place to do it than in their home? And if you can't physically go 2 hours away and 2 hours back and spend the whole day doing it, what a great vehicle to help with that in a way that, I think is very user-friendly.
Oh my gosh, that's such a good point. I could go on and on about that. But yeah, I remember one of the first therapy patients before Within that I was treating. And it actually was one of the things that sort of convinced me that telehealth could work, this particular patient. And she was a young lady in her late 20s, but she always zoomed in with me with her ballet slippers right in the back, like that were like when she was like 7 years old. It was always like in the, and I was just like, well, that is really, really interesting that her, little girl ballet slippers are right up there shining themselves onto me. What is that all about? And there's just countless, examples of things like that you just read a lot about people, and people learn a lot about themselves doing the work in their home.
Thank you, panelists. I know I can probably speak for the entire audience. We all want to just thank you, each and every one of you, for your advocacy for your patients and your drive to really connect with them and really just meet them where they're at. So I'm sure I can speak for everyone here and wanting to thank the three of you for that. Just make that blatantly clear. Moving on to the next question. Behavioral healthcare often involves interdisciplinary collaboration. How can healthcare providers and payers encourage teamwork and coordination among professionals to deliver personalized care?
I'll jump in. I'll speak. I'm not sure I'll answer the whole question, so I'll rely on the two of you. But, one, it's important, right? I think especially if we're talking about eating disorders, I think there's a lot of people that are scared off from working with eating disorders because of the need for there to be such collaborative effort. I think there's a myth that exists that you have to be able to attend to everything. And that's actually really not true. It's important to have a team where each person is attending to different aspects of the care. And, whether it's physical, whether it's therapy, whether it's nutritional, whether it's medications, not one person should ever be doing all of that. If you can have a team that's collaborative and in good communication, I think there's this implicit message to the patient that all these people care about me and they're all talking about me. And while that may at some level be uncomfortable, it's evidence that they really care and that they're trying their best to help me. And how can insurances help with that? I mean, that's a more difficult question for me to answer. I know that in my experience, some insurance companies, although it's probably been a while since I've heard this, will sort of demand that there is a team in place. And I think that's good protocol to sort of, leads to good practice within institutions. But I'm not exactly sure how to answer that second part of the question.
Do you want to take that second part, Tom, or whatever?
Sure. I think integration of care is very important. Even simply if somebody's taking an antidepressant prescribed by their psychiatrist, their primary care doctor should know about that.
Yeah.
And that psychiatrist should know what medical medication somebody's taking. But, with eating disorders, it's really extremely important because oftentimes you've got a therapist, psychiatrist, family therapist, nutritionist, primary care doctor, sometimes an adolescent specialist. If somebody's struggling and the PCP notices that, the rest of the team needs to know that too and respond to that. So that's really important. At Blue Cross Blue Shield of Vermont, we actually have an integrated care management team where we identify members with mental health issues and also medical issues, and we reach out to them and we work with them. We work with their families, their providers, make sure that they have the right appointments set up and that all that care is coordinated, and provide information, education on those on those issues too. So that's something that, a payer can do. Not all payers actually do case management of mental health issues. A lot of them just focus on the medical, but it can be really important and helpful for families and patients.
Yeah, when we first started within, I had reason to be in touch with a therapist. I knew she was out of South Carolina, actually. And she was just telling me how burned out she was because of just not having that multidisciplinary team and just feeling the weight of the world on her shoulders. And one thing that is really, really, I love this about within, it just warms my heart. I mean, if somebody needs an IOP or PhD level of care, like once they're in the door with us, they literally have that entire multidisciplinary team at their service, including like nursing, which coordinates with the medical care and like remote patient monitoring and obviously vital signs and weight restoration protocols, nutritionists, food specialists. I'm not trying to make this like a within like advertisement or something. I'm really not, but it's just like, it really does warm my heart. And she, told me just how grateful she was because she was just holding that hot potato and there wasn't people available to serve in those roles. And it just kind of is just amazing if you think about it, how difficult it is to get that multidisciplinary team together on an outpatient. When I was doing outpatient, I remember trying to get a team meeting together and it was like, whoo, that was like a couple weeks in the planning. And this opportunity to just wrap this team around, the patient and even the outpatient provider. The outpatient provider sometimes stays involved, or the psychiatrist can stay involved. Like there's really, we don't have to do it one exact way every time, but it's just a really nice feeling to see that patient walk in the door and just have that team, right as soon as they're with us. It's fulfilling.
Thank you, panel. And it looks like we have time for one more question. What challenges do healthcare providers face when implementing personalized approaches, and how can payers assist in overcoming these obstacles?
You want to start? Who wants to start with that one? David, you seem like you have ideas popping through your mind.
I think, again, I sort of alluded to this earlier, the sort of notion, and so you did as well, Wendy, the sort of notion of attunement, but really trying to meet people where they're at, and sometimes that involves somewhat idiosyncratic approaches or thinking outside of the box, and that's not always supported from an insurance standpoint, but it may be essential, and it may be on a cost-benefit analysis actually good for both parties, whether that's building rapport, whether that's designing a somewhat different kind of meal plan, whether that's a really sort of out there exposure and response prevention plan. The freedom to do that is essential when you're dealing with people that don't fit neatly into constructed boxes that we call diagnoses, and very few people do. So it's I think the more we can do that, it really gets back to what we opened with, the notion of trying to personalize the care. I think often the better the outcome, and I think that's better both on an insurance standpoint, but certainly most importantly for the patient and their families.
Yeah. One of the things that I think is really important that we are seeing more in our space now is this notion, that has been held, and I think in the past, that there's this evidence-based treatment, involves double-blind placebo-controlled studies, and that's the only, evidence that actually counts. And that's really doing a disservice to ourselves as clinicians and for sure to our patients. And I think sometimes even I think that term almost gets just overused and people attach to it. I think evidence-based treatment. And it's important to also remember that there's more than one kind of evidence, and lived experience is actually a form of evidence. Clinical experience is a form of evidence. So, what's really interesting to me is that if you think about, for example, EMDR was developed by Francine Shapiro, who was a psychologist who was walking through a park. She had a sister that had cancer, I think, and she was very depressed, and she was gazing left and right and left and right. This gave her the idea of what eventually came EMDR. Marsha Linehan, lived experience, so I personally felt myself through my own lived experience of my eating disorder really informed me, but I couldn't necessarily, prove it in I don't have the time or the money to go ahead and, prove that. So I do also understand, though, we don't want people just doing, crazy things with their patients. So it's like a balancing act. But I think, I'm not even sure if I'm specifically answering the question, but I think it just wanted to get that point across that our clinical experience is like a very important, evidence. I remember doing equine therapy, and the insurances are like, oh my gosh, that's not evidence-based. It's like, it sure as heck seems to help my patients come inside and complete their meals, so this sort of thing like really matters. I think, what it boils down to is a trusted partnership also with the payers. If there's a trusting relationship there, I think that's where we need to come more together as like feeling like a team, like when we're helping our patients, not like, oh my gosh, I've got to call the insurance and they're going to deny me. And like, I'm trying to advocate for, because that's kind of what is, I literally have anxiety when I do utilization review. Like, oh my gosh, to this day, I still have anxiety. So it would be nice to getting more payers and providers in the same rooms, to develop that trust. What do you think, Tom?
Yeah, I think anytime you get people face to face, it's helpful, and reduces that adversarial barrier. When I came to Blue Cross Vermont, I had spent so much time in the clinical world, and kind of hospital side of things that I worried, am I going to the dark side? But actually, I found a lot of opportunities to help and do some good here. For example, one of the first things I did was to work on removing prior authorizations for all levels of care for mental health and substance use treatment for in-state and network providers in Vermont. So, people don't have to jump through those hoops. We don't have any limits on therapy or psychiatry visits now. So we were able to do that. I was able to kind of initiate and work on that. But
standing ovation, Tom. Wow, no prior authorization. Did you guys hear that? You deserve a standing ovation. Thank you. Thank you for doing that.
Thank you. And I think with the pandemic too, there's been a greater realization about the role of mental health and how it relates to also medical issues, and making sure that we have access to care and treatment, and that it's something that can't be ignored anymore. So I think those are all things that payers can focus on.
For sure. Wow, that's such an accomplishment, Tom. Thank you.
I'll just add a little bit more, because Wendy, your point about the evidence-based treatment, while I'm all about evidence-based treatment, the great thing, it isn't the end-all be-all, and especially with eating disorders, and very, very underfunded in terms of research.
Yeah,
comparatively, probably I think among psychiatric diagnoses, one of the two lowest funded for research. So it's very hard to have that. We might have some evidence-informed therapies, but if we go with a gold standard, we're really left with, we can't do anything. And we do have some sense of things that are useful in that work.
For sure.
So I really appreciate your speaking to that, and also the lived experience and the clinical experience as being its own evidence. I've not heard that put in quite such a simple term. I think it's incredibly important to hold that as a significant weight in determining what care we deliver.
Yeah, thank you. Means a lot to me to, for me personally, starting my first treatment center, I was really it was 2003, and I was going off my lived experience. Yeah. I didn't have there was no manual of how to do it. There was nobody training me how to do it. It was just like, I'm making a residential program now. What am I going to do? And it was really lived experience, probably more than anything else, that informed me. And just, I think, the natural desire to do attuned care. And I think we really miss out on that if we don't allow that lived experience to inform our care of the patients and of the providers.
Wonderful. Thank you, panel. And I also wanted to open it up as well. I know we have a few more moments. Actually, this panel goes until 3 p.m. Eastern time today. One thing I always like to do too, if there are any questions for the panel, the chat option is available as well. I will also provide my email in the chat as well in case anything does come up and we want to relay that as well. So since we had some extra time, we do have time for one more question in case anything does come up in the chat. So for the panelists, looking at finalizing this presentation, can you share any success stories or case studies where a personalized approach to behavioral healthcare significantly improved patient well-being? Just share any stories for these last couple of moments we have together.
Who wants to start?
So many stories, but I think this maybe ties together a lot of what we've been talking about. When I was working as a clinician, to do team meetings was really impactful, helpful, and also rewarding. I remember sitting, with individual and family therapists, myself, a nutritionist, with the patient, their family, and we could really kind of get at all the issues and sticking points. And what I found most helpful was that somebody would raise a question, the patient might say, "Why are we doing this?" or "I hate this," and kind of be pushing back on something, and I'd kind of be scratching my head like, I don't think I have the best answer here. And then somebody like David would chime in and say the most insightful, profound thing, and it was so helpful. And I would just think to myself, oh, thank goodness we're in this team meeting where everyone can really contribute, and
Nice.
that's really personalized, kind of one-on-one or 8-on-3 therapy. But it's really how you can make an impact and also reduce this kind of splitting of providers and making sure everybody's on the same page. So that's kind of one of my favorite aspects of treatment are these team meetings where everybody kind of gets on the same page and works together.
Yeah, I love team meetings. Whenever I come to a team meeting, I don't even feel like I'm working. I'm so invigorated by the ideas and the passion and the different views, coming together. It's just I think it's part of the joy of doing this work for sure. David, did you want to share?
It's funny when you talk about stories. There are a lot, and I think with eating disorders in particular, they normally involve sort of being flexible to some degree when someone gets stuck.
Yeah.
And the greatest success stories obviously have adversity behind them. That they're not easy.
Yeah.
But the first story I thought of had nothing to do with eating disorders. It was a patient that I was working with just out of graduate school, and I was on an inpatient psychotic disorders unit. And to this day, it's the only patient I've ever met who was a catatonic schizophrenic. He literally didn't really move or speak. And, I was going in daily to meet with him. And, how do you work with someone who won't speak to you? And so I talked with his family, tried to get a sense of, what he liked and what his interests were. And I found out he was a big baseball fan and a Yankees fan. So I would come in every day and I would read him the Yankees box score and tell him about the game. And I could tell he was sort of listening, but I didn't know, really what was going on. Eventually, with some time and some medication, maybe a couple of weeks in, I went in and after reading the last night's box score to him in the game, I said, full disclosure, I have to tell you, this is one of the hard parts of my day, because I'm a Red Sox fan and I'm reading to you about the Yankees and they're doing really well. Tiniest little bit of a smile was the first affect that I'd gotten from him in 2 weeks.
Wow, that's so cool.
From there, it sort of emerged, but it's like, really, again, thinking outside of the box and trying, to be curious as you approach.
And you were not doing CBT, you were relating to the patient. And
no, there was no evidence-based theory around the box score.
Yeah, you didn't read in a manual, yeah. Well, I am going to have a lot of fun right now because we have we use Slack within, and we have a thing called wow moments. So this kind of inspires us when somebody has some experience, with one of our patients. We'll share it. We don't give the name or anything. It's just a wow moment, and I'm going to share a wow moment if I can with you from last night. It says this. Hey team, would just like to share that tonight in Mature Adults group, A client who has been really struggling with hopelessness about her recovery for several months spoke to a major win of trying on jeans this weekend, realizing that they didn't fit, and quote, I just took them off and put something else on, and I didn't even think about it. She then went to a restaurant with her daughter and had a blast. It moved many members of the group to tears as they were so proud of her, inspired by her, especially knowing how hopeless she had been over the last few months. She in turn felt such love and recognition from the group that she had her own happy tears. It was a very, very sweet and powerful moment and an honor to witness. So
Awesome.
that makes me feel good, especially knowing it's a mature adults group, because anybody can heal at any point in time. Our soul wants to heal. We just have to get fed the right ingredients. So I think we have probably a wrap here, right? Let's see.
Yes.
Emily, I saw your message about the weight stigma thing. So thank you for that. About the paradigm shift. Thank you.
Wonderful. I want to make sure you saw that too, Wendy, and that you're getting extra love. And I want to thank each of the panelists for their expertise, for sharing their different stories with the group and how they related to their patients, and then ultimately just being the best advocates. This world of telehealth is obviously something newer, and just really being the best each of you can for your patients is incredibly huge, especially in this environment. So I want to make sure each of the panelists know how grateful we are to have them in our summit. Another thing I want to also provide in this space, we do have some more additional events coming up within Summit. We have a few more this afternoon that are worth a check out. We also have another day tomorrow. So please, if you're registered, definitely go through those events. We have some wonderful speakers provided here for us and really take advantage of those. We have some really great learning experiences and just really great insights. So make sure you check out those and celebrate our Within Summit with us. And again, thank you to the panelists. Thank you to everybody that was in this space with us today. You are all appreciated so much.
Thank you very much, Tom. I'm so grateful to you for working on the payer side. Like, we really need people like you on the payer side. So thank you so much for that. I really feel supported in knowing you're there. And David, it was so nice to meet you. I've heard nothing but amazing things about your program. So it meant a lot to me to be on a panel with both of you.
Thank you, and thanks for having me.
Yeah, thank you for having us.
Bye, everybody. Thanks for coming, everyone. We appreciate it.
Bye-bye.
Bye.